Yes. So a very good afternoon. I'll be dealing with vergence and accommodation dysfunction, which causes asthenopia. No financial interests. So is it really important to know whether the accommodation or vergence is causing the asthenopia? And how do we diagnose and go about it? Because many children we diagnose as learning difficulty, actually they might be having accommodation and vergence issues. As well as cricket players or tennis players, they need good depth perception. Accommodation and vergence can hinder this. According to the change in visual needs in the present scenario, from a good distance visual acuity and stereopsis, we need an emphasis on near work. And this actually gives a lot of strain on our accommodation and vergence, which needs to be sustained without fatigue. The symptoms and signs, as already described, are blurred vision, headache, motion sickness, and all the plethora of signs that we see. And we have difficulty in computer work and near work. And ultimately, it leads to a drop in performance or inattentiveness. So how can we assess this, and what is the pathology behind it? We have a fusional supply or a fusional vergence ability, which is combating the fusional demand. The fusional demand is the phoria at a given distance. So the fusional vergence ability will combat this, and it is bridged by accommodation. It's just like a balance with two plates having phoria on one hand and the fusional vergence on the other, which is bridged by the accommodation. So we need a good balance between these two. So how do we diagnose this? Are there any diagnostic dilemmas? First and foremost, we need to do a full plus refraction with binocular balance, and we have to measure the phorias, how much it is. The next step would be measuring the vergence, and the last would be measuring the accommodative convergence. We have different techniques to measure phorias, but we usually use the prism bar method. Modified Thornton method is another one. We have Von Graffe method. All these are read from charts. We can use this if we need more standardization. So how do we calculate how much of vergence ability is needed to combat this phoria? So we need at least twice the fusional vergence to get combat the phoria. So phoria into 2 will give you the fusional vergence which is needed. So this is called Sheard's criterion. And vergence, as we all know, is a disjugate movement. There are different types of vergences, and we all know about how to denote and what is the unit of vergence. We check vergence mainly in 3 forms. One is the blur, and the second one is the break, and the third point is the recovery. So this will give us an idea regarding the vergence amplitude. So it can be done either as a smooth vergence testing when we use the phoropter, or it can be used as a step vergence testing when we use the prism bar. But these 3 points are mainly evaluated when we test vergence. Sorry for that. There is a little bit problem with my. Okay, so the near point of convergence can also be ruled, evaluated with the RAF rule. The second part of vergence evaluation is to check the dynamics of the vergence. That is by using a flipper. We use base in and base out flippers to test the agility of the vergence system. So this gives us an idea how much we can stress the vergence system. And last but not the least, we have to check the accommodative convergence. That is the amount of convergence induced per diopter of accommodation. And this is usually the same from childhood to at least presbyopic age, and it needs to be normal to avoid symptoms of asthenopia. There are different methods. I usually use the gradient method. And depending on these things, we have the Duane-White classification. The phoria for distance and near is calculated with the AC by A ratio, and we classify diseases into convergence insufficiency, excess, or divergence insufficiency, or excess. Vergence anomalies in children need special regard because this can be either convergence insufficiency or convergence excess, as already mentioned. But fusional vergence dysfunction is something which is more important in children, which results in heterophoria. Convergence insufficiency is actually a widely studied topic, and there are set criteria for evaluating convergence insufficiency. It should be more than 4 prism diopters of difference for near and distance, the FORIA. The Sheard's criteria should be failed, and the recorded near point of convergence is larger. It's more than 7.5 centimeters. We can also assess the convergence insufficiency with survey sheets like the CISS survey, which gives a positive result if it is above 16. So convergence excess, as we already mentioned, is diagnosed with the Duane's-White classification as well as divergence problems. Pseudo-convergence insufficiency is something we need to look into because we could mistake it as a convergence problem, but it is actually an accommodative problem which is underlying. So at least we should test it with fogging, and +1 lenses should be given to relieve the accommodative strain. Fusional vergence dysfunction, they'll have a normal AC by A ratio. The FORIA will be within normal range, but they'll have reduced fusional amplitudes. Now the second half of the balance system, accommodation dysfunction. Unfortunately, accommodation dysfunction is less studied than convergence insufficiency. More than 50% of the studies are for convergence insufficiency. There is no different questionnaire for children, and most of the studies are for near vision. And the diagnosis of accommodation insufficiency is for the same reason, it's difficult. And the diagnostic criteria are not very standard. And hence, for the same reason, different studies report less than 1% to 61.6% of accommodation insufficiency in their studies. This is the reason for a wide variation in the percentages. Diagnosis of accommodative insufficiency, in the same way as we test convergence, we need to check the amplitude of accommodation as well as the agility of the accommodation system. The amplitude of accommodation is by standard evaluated by the Hofstadter's formula, which gives us the average accommodative amplitude as well as the minimum and maximum amplitudes according to the age. So this gives us an idea of how the accommodation is. Monocular estimation method and not retinoscopy are other techniques. So accommodative response usually shows a lag of 0.4, but if it is more than 0.75, it diagnoses accommodative insufficiency. And accommodative facility is tested using flippers in the same way as convergence. Only thing is we use plus and minus flippers. Computer assisted techniques are there. This is an edge, gives us an edge over the standard evaluation because you can clearly demarcate between vergence and accommodation anomalies. We have Indian normative data for accommodation and vergence because most of them are foreign data. So Indian data is given by the band study from Tamil Nadu. Even in this study, convergence insufficiency is the largest studied. Disorders of accommodation could be insufficiency, ill-sustained or in-facility. And most of all, we should rule out any neurological diseases that cause convergence and accommodation insufficiency before landing into a diagnosis of pure convergence and accommodation problems. So how do we treat this, and is the treatment effective? The general treatment guidelines, glasses will be discussed in the subsequent talks. We can give prisms, we can give vision therapy, and surgical correction is another option. So glasses will be described in the subsequent talks. So I'm not going into the details. We just need to check for FORIAs and AC by ratios while prescribing glasses if they complain of eye strain. Prisms, the basic rule is we follow the Sheard's criteria. 2/3 the FORIA minus 1/3 the compensating fusional vergence. This gives us an idea of how much of prism correction we need to give. So we can give horizontal relieving prisms. Prisms are also given either prior to vision therapy or as a maintenance for vision therapy. So why do we use vision therapy? It actually improves the amplitude of accommodation, the agility of the accommodative system. It relieves spasm and improves stereopsis, especially in children. There are different types of vision therapies, home-based and office-based. Home-based could be either pencil push-ups using 20/60 letters. Variable tranaglyphs and non-variable tranaglyphs are there. They usually employ red-green goggles. Variable hectograms are there, which use Polaroid glasses and printed Polaroid matter. And we have our computer orthoptics random dot stereopsis, which is mainly an office-based therapy. There are other programs which do give home-based computer support as well. We can use the age-old septums and apertures. They are actually good instruments in treating for office therapy. Brock strings, which can be given for home-based therapy as well. And we have meta-analysis, which suggests that office-based therapy with home-based reinforcement is actually efficient in treating these non-strabismic binocular vision abnormalities. And we have randomized controlled trials which have evaluated these two and gives us these data. So thank you very much.